Welcome to the deep dive.
Great to be here.
Today we're tackling something that might sound a bit technical initially, azotemia and uremia,
Right.
but really think of it simply. It's about understanding what happens when the body's natural filters, the kidneys, aren't quite keeping up with clearing out waste.
Exactly. It sounds complex, but it's fundamental.
We've got some really good material here, this pasted text, that walks through what these conditions actually are, what causes them, and, well, the ripple effects they can have.
Yeah, it's quite comprehensive.
So our goal in this deep dive is really to pull out the essentials, make sense of the key differences and impacts without getting bogged down in overly complicated medical terms.
We want you to walk away with a really clear grasp of these conditions and why they matter.
Okay, so let's start right at the beginning. The absolute basics. What exactly are azotemia and uremia in plain English?
Well, pasted text defines azotemia as basically having too much stuff like urea and creatinine in your blood. These are like waste products from your body just doing its normal thing, metabolizing proteins and such. Normally, your kidneys filter these out.
Right, into urine.
Exactly. So azotemia is like having too much of that exhaust, you could say, building up inside.
Got it. Azotemia is the buildup. So then how does uremia fit in?
Uremia, according to our source, is what happens when that buildup starts causing problems body-wide. It's described as a polysystemic toxic syndrome.
Polysystemic meaning many systems.
Yeah, affecting lots of different parts of the body. It happens when kidney function gets really low, and it often goes hand in hand with that azotemia we just mentioned.
Okay, so azotemia is the high waste levels in the blood, and uremia is sort of the so what? The actual sickness that results when the kidneys just can't cope anymore.
That's a good way to put it.
And the text makes a point, which seems really crucial, that you can have azotemia without having uremia.
Absolutely. That's a key distinction.
So someone could have those elevated waste levels, but not feel obviously sick in that full-blown uremic way.
Precisely. Azotemia might be an early sign, like a warning light. The body might still be compensating, enough to prevent those widespread toxic effects of uremia, at least for a while.
That makes sense. So let's dig into the why then. The pathophysiology of azotemia. What are the main ways our source says this buildup happens?
Pasted text points to three main scenarios. First, your body might just be producing more waste than usual.
How would that happen?
Well, maybe a super high protein diet, for example, or internal bleeding in the gut, where blood proteins get broken down, or even if your body's breaking down its own tissues faster than normal.
So it's not always the kidney's fault directly. Sometimes they're just overloaded.
Right, they're faced with a bigger job.
Okay, what's the second main reason?
The second, and probably more common one, is a decrease in what's called the glomerular filtration rate, or GFR.
The glomeruli. Those are the tiny filters in the kidneys, right?
Exactly, like microscopic sieves. If those sieves aren't working efficiently, they can't pull the waste out of the blood properly.
And why might they not work properly?
Well, this is where the text breaks it down into pre-renal, renal, and post-renal causes.
Right. Let's start with pre-renal. What's going on there?
Pre-renal basically means the problem is before the kidneys. It's about reduced blood flow to them.
Ah, like not enough liquid getting to the filter.
Precisely. Could be dehydration, low blood volume, maybe low blood pressure from heart issues, things like that. If the kidneys aren't getting enough supply, their filtering rate drops.
Makes sense. Okay, next up is renal azotemia. That sounds like the problem is the kidney itself.
Exactly right. Renal azotemia means actual kidney disease. Could be acute, like sudden damage, or chronic, developing over time.
And it can affect different parts of the kidney.
Yeah, the source mentions it can affect the glomeruli themselves, the tubules, the tissue in between, or even the blood vessels inside the kidney.
And it mentions something about needing to lose quite a bit of function.
Yes, it says typically at least 75% of kidney function needs to be lost before we see renal azotemia.
Wow, 75%. That's huge. The body must have a lot of reserve capacity.
It really does. Significant compensatory mechanisms are usually at play.
Okay, and the third type is post-renal azotemia. What's the issue there?
Post-renal is a problem after the kidneys. Think of it like a plumbing blockage.
Ah, like a blocked pipe.
Exactly. Urine can't get out properly, so waste backs up into the blood. Could be a stone, a tumor, something blocking the urinary tract.
The text also mentions urine leaking.
Right, another form of post-renal. If there's a rupture or leak in the urinary tract, urine can actually get reabsorbed back into the bloodstream.
Okay, so to recap the why for azotemia, too much waste being made, not enough blood flow to the kidneys, actual kidney damage, or blockage preventing waste from leaving.
That covers the main mechanisms, yes.
Now let's shift back to uremia, the illness itself. The text says it affects virtually every body system. That sounds, well, incredibly serious.
It is serious.
Yeah.
And it makes sense when you think about all the jobs the kidneys do.
It's not just filtering waste, is it?
Not at all. They regulate fluids, electrolytes, blood pressure. They produce important hormones. So when they fail, the fallout is widespread. It's not just the toxins building up, it's the disruption of all those other critical functions too.
Right. Let's walk through some of those affected systems. What about the cardiovascular system? What effects does uremia have there?
The text lists quite a few. High blood pressure is common. Thickening of the heart muscle, especially the left ventricle because it's working harder.
Okay.
You can also see heart murmurs, an enlarged heart overall, and problems with heart rhythm, arrhythmias.
That's a heavy burden on the heart. What about the endocrine and metabolic systems? Hormones and such.
Yeah, major effects there too. Something called secondary hyperparathyroidism that messes with calcium and phosphorus balance.
Uh-huh.
Then there's lower production of calcitriol, that's active vitamin D, needed for calcium absorption, and less erythropoietin.
Erythropoietin, that's the hormone for red blood cells, right? Explains why anemia is common.
Exactly. Anemia is a big one. The text also mentions increased gastrin, which affects the stomach, and often just general weight loss and wasting.
So the body's not just full of waste, it's also not making things it needs. Moving to the gastrointestinal system, what kind of symptoms pop up there? Sounds unpleasant.
Oh, it often is. GI issues are really frequent. Things like losing your appetite, feeling nauseous, vomiting, diarrhea, also mouth sores, a dry mouth, that distinctive bad breath, sometimes called uremic fetor, and constipation can happen too.
We mentioned anemia with the blood system, but what about immunity?
Yeah, besides anemia, uremia can weaken the immune system, makes the body more vulnerable to infections.
That figures, if the whole system is stressed. Now, the neuromuscular system seems particularly hit hard, according to the text. A really wide range of signs.
It really is. The neurological effects can vary a lot. It
Yeah.
might start with just feeling dull, tired, maybe irritable.
Okay.
But it can progress to more severe things like tremors, unsteadiness, muscle weakness, or twitching, definite changes in behavior.
Even more serious things.
Yes, the text mentions things like dementia-like signs, specific nerve problems, seizures, stupor, even coma in very severe cases.
Wow. And it mentions temperature regulation, too.
Right. Often leads to a lower than normal body temperature, hypothermia.
That's a surprising one. And the eyes. Can uremia affect vision?
It can. You might see redness in the eyes, damage to the blood vessels in the retinopathy, and sometimes even sudden blindness.
And the lungs. Respiratory system.
Yes, difficulty breathing or shortness of breath can also be a feature of uremia.
Finally, what about the skin? You mentioned paleness earlier with anemia.
Exactly. Pale skin or gums. Also increased bruising. The text mentions increased shedding of skin or hair, the coat looking unkempt, losing its shine, just a general poor appearance.
It's truly sobering how widespread the impact is. Okay, so how would someone, or perhaps a vet in the case of an animal, recognize that uremia might be developing? What are the clinical signs?
Well, the text points out, importantly, that azotemia itself, just the high waste levels, might not cause obvious signs right away.
Right, not until it becomes uremia or the underlying cause is bad enough.
Exactly. So the signs we often talk about are really the signs of uremia. Historically, what someone might report is things like, well, weight loss that you can't explain,
Okay.
changes in appetite, eating less, or maybe not at all, less energy, reduced activity, seeming depressed or lethargic.
General malaise, sort of.
Yeah. And then more specific things like vomiting, diarrhea, noticing bad breath, maybe constipation, changes in urination more, less, straining perhaps, and just that poor coat or skin condition we mentioned.
A collection of signs that individually might not scream kidney failure, but together paint a picture.
Right. They're often nonspecific initially.
So what might a doctor or vet actually find during a physical examination?
On exam, they might pick up on muscle wasting, mental dullness or depression, signs of dehydration, just general weakness.
Okay.
Paleness of the gums or skin, those pinpoint bruises called petechiae or larger bruises, that dull, unkempt coat again, the bad breath, maybe ulcers in the mouth, red eyes, and that lower body temperature.
Again, a range of things that could point towards this. Let's circle back quickly to the causes. We covered the three main types: pre-renal, renal, post-renal. Can we get a few more specific examples from the text?
Sure. Under pre-renal, besides low blood volume or pressure, the text mentions increased waste production from things like severe infection, fever, trauma, maybe excess steroids, even burns.
Stressful events for the body.
Yes. And also increased protein breakdown in the gut, like from that high-protein diet or GI bleeding.
Okay. And for renal azotemia, the kidney itself.
That covers a huge range of actual kidney diseases, acute or chronic, that damage the filtering units or other kidney structures enough to impair function significantly.
Right, that's 75% loss threshold again. And post-renal.
Mostly physical obstructions, stones, tumors, scar tissue blocking urine flow, or ruptures or tears in the urinary tract.
The text also lists quite a few risk factors, things that make azotemia or uremia more likely.
It does. Having existing kidney disease is a big one, obviously.
Mhm.
Hormonal issues like Addison's disease, heart problems affecting circulation, infections, fever, conditions that cause excessive urination like diabetes, liver disease, uterine infections in females, low blood protein levels, dehydration, acidosis.
It's a long list.
It is. Also exposure to kidney toxins, GI bleeding, urinary stones or blockages we mentioned, urinary tract trauma, tumors, and even just advanced age is listed as a potential risk factor.
Really shows how kidney health is tied into overall health. And what about medications and specific toxins?
Huge factor. Certain drugs are directly nephrotoxic, damaging to the kidneys.
Hmm.
Some NSAIDs, certain antibiotics, chemotherapy agents,
Right.
diuretics, some blood pressure meds can also contribute,
Yeah.
especially if doses aren't adjusted for existing kidney issues. That's a critical point the text makes.
Adjusting dosages for patients with poor kidney function.
Absolutely vital, because if the kidneys aren't clearing the drug properly, it can build up to toxic levels, or the drug itself might worsen kidney function.
And specific non-medical toxins.
Yeah, the text gives classic examples. Ethylene glycol antifreeze, super dangerous. Grapes and raisins for dogs, lilies for cats. Important things for pet owners especially to be aware of.
Definitely. Okay, so if azotemia or uremia is suspected, how does the diagnostic process work? How do doctors figure out what's going on?
Well, first they consider other things that could cause similar signs of differential diagnosis, like is it just dehydration causing prerenal azotemia, or did the patient just eat a massive protein meal?
Ruling out simpler explanations first.
Right, and the history is key. How quickly did symptoms start? Any changes in urine output, known toxin exposure,
Yeah.
that helps differentiate between prerenal, acute renal, chronic renal, post-renal.
And then come the tests, I assume. Blood work, urine tests.
Exactly. Lab tests are crucial. A CBC complete blood count might show anemia, often seen with chronic kidney disease, or hemoconcentration thick blood, which can happen with dehydration in several types.
Okay.
But the biochemical profile is really central, looking at BUN, blood urea, nitrogen, and creatinine levels, and importantly, monitoring them over time.
How does monitoring help distinguish the type?
Well, how those levels respond to treatment gives big clues. For instance, if BUN and creatinine drop rapidly after giving IV fluids, that strongly suggests prerenal azotemia.
Ah, because you fixed the blood flow problem.
Exactly. High potassium levels can be a red flag for postrenal obstruction, or very severe acute kidney failure, or sometimes prerenal issues, plus other conditions like Addison's. High protein levels in the blood, albumin and globulin, might also point towards prerenal.
So the patterns in the blood work are really informative. What about the urinalysis looking at the urine itself?
Also very important. It tells us how well the kidneys are concentrating urine. In a patient who isn't dehydrated but is azotemic, if the urine is highly concentrated, that supports prerenal azotemia, the kidneys are still trying hard to save water.
Makes sense.
On the other hand, if the urine is dilute like water in an azotemic patient who hasn't had fluids, that usually points to primary renal azotemia. The kidneys have lost that concentrating ability.
Okay. Any exceptions?
Yes. The text mentions glomerular disease damage to the filters themselves. There, you might see a lot of protein in the urine, which is the key clue, even if the urine concentration isn't completely lost yet. And urinalysis isn't very helpful for diagnosing postrenal causes.
Got it. The text briefly mentions more specialized tests, too, for GFR.
Right. Things like creatinine clearance or other clearance tests can give a more precise number for the actual filtration rate, but they're often more complex to perform.
And imaging, x-rays, ultrasound.
Absolutely essential. Abdominal x-rays can show kidney size. Small kidneys often mean chronic disease, and large kidneys might suggest acute failure or a blockage. X-rays can sometimes show stones, too.
And ultrasound.
Ultrasound is great for looking inside the kidneys at their structure, and it's excellent for ruling out postrenal problems, looking for dilated ureters, stones, masses, or fluid suggesting a rupture.
Okay. Sometimes more advanced imaging, too.
Yes. Contrast studies or CT-MRI might be used if obstruction or rupture is strongly suspected, but not clear on initial imaging.
And finally, a biopsy.
In some cases, yes. A renal biopsy, taking a tiny piece of kidney tissue, can give a definitive diagnosis of the type of primary kidney disease, which can sometimes guide treatment or prognosis.
So it's really a multi-pronged approach: history, exam, labs, imaging, to get the full picture.
Definitely. You need to put all the pieces together.
Once a diagnosis is made, what's the general game plan for treatment? How does it differ for the types of azotemia?
It really depends on the cause. For pre-renal, the goal is to fix the underlying issue causing poor blood flow, usually aggressive fluid therapy, to restore hydration and blood pressure.
Okay.
For primary renal azotemia and the resulting uremia, treatment is more complex. You try to manage the underlying kidney disease if possible, but often it's about supportive care.
What does supportive care involve?
Correcting dehydration, electrolyte imbalances like high potassium or phosphorus, managing acidosis, providing nutritional support, controlling symptoms like nausea, and addressing hormone deficiencies like anemia if possible.
And for post-renal?
That's usually more straightforward, at least initially. You have to relieve the obstruction or repair the leak as quickly as possible, get the urine flowing again.
Fluid therapy seems like a common thread for most patients.
Very common. Most azotemic patients are dehydrated to some degree. Fluids like saline or LRS are used to rehydrate and improve kidney blood flow.
That you have to be careful.
Absolutely. The text warns about fluid overload, especially in patients with heart failure or those who aren't producing urine. You have to monitor them very closely.
Makes sense. What about other things like special diets or medications?
Yes, kidney-specific therapeutic diets are often a cornerstone of managing chronic kidney disease. They usually have modified protein, phosphorus, and sodium levels to reduce the load on the kidneys.
And meds for the uremia symptoms.
Right, things like anti-nausea drugs,
Yeah.
appetite stimulants sometimes, medications to reduce stomach acid, phosphate binders to control phosphorus levels.
And crucially, avoiding certain drugs.
Yes, big caution there. Avoid any known nephrotoxic drugs. And be super careful with dosages of drugs that rely on the kidneys for excretion doses. Often need to be reduced significantly.
The text also mentions corticosteroids might worsen things.
Right, because they can increase protein breakdown, which increases the nitrogen waste load the kidneys have to handle. So generally avoid it unless needed for another specific reason.
It sounds like a very careful balancing act. What about follow-up after treatment starts?
Close monitoring is key. The text mentions rechecking kidney values, BUN, creatinine, electrolytes, hydration status, body weight, and urine output frequently, often within the first 24 hours, especially after starting fluids, to see how the patient is responding.
And what happens if azotemia isn't treated properly? What are the potential complications?
Well, if prerenal azotemia isn't corrected promptly, that lack of blood flow can cause actual permanent kidney damage, turning it into renal azotemia.
Okay.
Untreated primary renal azotemia obviously progresses, leading to worsening uremia and all its complications.
And post-renal?
If an obstruction isn't relieved, the back pressure causes progressive kidney damage. You can get life-threateningly high potassium levels, and eventually severe uremia can be fatal.
So, bottom line, early diagnosis and prompt appropriate treatment are really critical for a better outcome.
Absolutely. Time matters.
Okay, let's try and summarize the main takeaways from our deep dive today. What are the absolute key points about azotemia and uremia?
I think first is that core distinction. Azotemia is the biochemical finding the waste in the blood. Uremia is the clinical illness, the body-wide sickness resulting from failing kidneys.
Right, azotemia doesn't always equal uremia.
Exactly. Second, understanding the type of azotemia, prerenal, renal, or postrenal, is essential because it dictates the treatment strategy. You treat the cause.
Makes sense.
And third, just appreciating how incredibly widespread the effects of uremia are. It really underscores that kidney health isn't isolated. It's deeply connected to the health of almost every other system in the body.
Absolutely. It's a complex topic, but breaking it down like this hopefully gives you, our listener, a much clearer picture of what's going on when that vital filtration system runs into trouble.
Yeah, it highlights that interconnectedness.
And considering that interconnectedness revealed in uremia, it really makes you wonder, doesn't it? What other health issues that seem quite separate on the surface might actually have surprising roots in how well our different organs are functioning? Maybe something for you to ponder and explore further.
A good thought to end on.
Thanks for diving deep with us today.